Dear friends and colleagues, welcome to the preview from the Thoraxcenter of the 2022 ACC meeting that will be held in a couple of weeks in the United States. And as always, it's a great pleasure to present this together with my good friend and colleague Joost. What we're going to do is, again, we're going to evaluate all the studies that will be presented as late-breaking trials that seem of interest to us. And you will see a variety of trials from the interventional space to heart failure to electrophysiology. But first, I think one of the interesting trials to us at least is the Pacman AMI. Erasmus MC was involved in that study, but more in particular, Joost, you were involved. So yeah. What is it all about?
Yeah, so Pacman is a very interesting trial. It's a randomized controlled superiority trial assessing the efficacy of Alirocumab on coronary artery disease progression and actually atherosclerotic disease progression in non-culprit vessels in patients presenting with acute myocardial infarction. So the trial enrolled 300 AMI patients, so either NSTEMI or STEMI within, I think, 9 European hospitals that underwent multimodality imaging of 2 non-infarct-related arteries at baseline and then again at 1 year to assess the primary endpoint of change in percentage atheroma volume change. And of interest, also a LipiScan endpoint. So NIRS with the LCBI 4 millimeter change from baseline to 1 year. So that is interesting. I think intriguing and also very novel, because if you look at previous trials like GLAGOL, for instance, which studied which had a similar design, but then looked at Evolocumab and actually demonstrated a 1% decrease in percentage atheroma volume between baseline and 1 year. However, that trial included patients with stable coronary artery disease, which we know is a little bit of a different league of patients as compared to those presenting with AMI. Plus, there was no NIRS data, and I think that adds to the Pacman trial, which actually adds the LipiScan findings and OCT to this multimodality imaging to assess change in LCBI, but also fibrous gap thickness as an OCT endpoint. It also follows Odyssey J-IVIS, which actually was negative. That was a study with Alirocumab, but had a very shorter duration of follow-up, only 32 weeks as compared to a 1 year endpoint in Pacman. So findings, I think, to look out for, and I think a trial that will learn us on what could potentially help in guiding optimized medical therapy in patients with ACS.
Well, and it is also part of a series of trials. There's also the Huygens trial, obviously, that is looking into the effects of PCSK9 inhibitors in the context of plaque progression, plaque stabilization, and maybe even plaque reduction, right? So I think it makes total sense, these kind of studies, and I really look forward to the results of this one.
Yes, me too.
Then there's this other, then we switch gears, we go to patients with hypertrophic cardiomyopathy. And this is an interesting study, the Valour HCM, a randomized controlled trial, where they are looking at the impact of Mavacamten. Mavacamten is an inhibitor of cardiac myosin, and it has already been demonstrated to improve the symptoms and exercise capacity in patients with HCM. This trial now will randomize patients to early septum reduction therapy, being either surgery or alcohol ablation, versus the Mavacamten therapy, and they will then look at a composite endpoint of the number of patients who eventually will decide to proceed to septum reduction therapy at week 16. It's a little bit of a complex study because you have 16 weeks of placebo-controlled treatment. So half of the patients will get Mavacamten, the other half will get placebo. And then there is 16 weeks of active blinded treatment, and then another 96 weeks of treatment extension. So it's quite complex, but the core of the matter is that those first 16 weeks, patients will be randomized, and they are symptomatic, by the way. So they will be randomized to see whether Mavacamten can reduce their symptoms, can improve their quality of life. So I think from a concept point of view, quite of interest, whether we should be more aggressive or whether we can rely on this new medical therapy.
Yeah, I think it's interesting. It follows the Explore HCM trial that was published by John Spurtis last year in The Lancet, also already demonstrating the potential effect of this novel drug, at least in reducing symptoms and improving quality of life. So I look out for the data.
Me too.
Good. More on drugs is a small randomized trial that we wanted to highlight called the EDIT-CMD. It's a small randomized controlled trial from Nijmegen studying the efficacy of diltiazem to improve coronary vasomotor dysfunction in patients with angina and non-obstructive coronary artery disease. So small trial, as mentioned, 85 patients. That will undergo coronary angiography for stable angina, and in case they have no obstructive coronary artery disease, they will undergo extensive physiological assessment with IMR and CFR assessments. And in case there is evidence of microvascular dysfunction, either being a CFR below 2 or IMR above 25, then they will be randomized 1-to-1 either to the diltiazem or a placebo. These patients will subsequently undergo a repeat angiography at 6 weeks, undergo the same physiological assessment to assess the primary endpoint, which will be a change in improvement of these physiological parameters. I think it's an interesting study. It would be the first to really assess the objective effect of diltiazem with some more objective parameters as just quality of life or angina quality. In a subgroup of patients that is not so rare. I mean, we in our tertiary academic center maybe don't see them that much, but at least in the Netherlands, in sites where they do a lot of angiography, there is 30 to 40% of patients without obstructive coronary artery disease, whereas we know that half of them might have microvascular dysfunction, particularly also in women now, a topic of hot debate. So small study, but I think of interest.
Me too. I think it really studies a pathophysiological mechanism. But whether it will change our practice in a significant way, that's a different story. But these are the studies that also are very valuable, I think, to get more and more insights in what we're doing. So there is also the PROMPT-HF. The PROMPT-HF study is a little bit of an interesting study because it randomizes basically physicians who are treating their patients with heart failure. More than 1,000 patients in the United States will be randomized 1-to-1, and the randomization basically holds or relates to the treating physicians. So the physicians will get either some kind of an electronic health record-based alert informing the provider about evidence-based medications for HFrEF versus usual care in outpatient clinics, but also how the patient is doing in terms of ejection fraction, in terms of lab results, and so on and so on. So basically, it's an alert feature, and to me, it's a little bit I don't know. It's a little bit a strange thing because I would think that as a healthcare provider, you are aware of what is happening to your patients, but it seems that reality is a little bit different. And we also know from CHAMP-HF and CHECK-HF, large registries that demonstrated in the United States and in the Netherlands that the uptake and the adoption of heart failure medical therapy is below par. Yep. And not only the uptake of the medications, but also the up-titration to the doses that are required from the randomized control heart failure trial. So it is a little bit of an interesting feature, an interesting twist on how we are treating our patients. Let's see what the results are.
I'm also curious. I think compliance in this day and age is something that really deserves a lot of attention. It's much lower than any of us would ever have hoped for. That is something we're learning more and more, and I think all measures that could help to improve compliance are most welcome. So interesting.
Okay, then FAME3.
Yeah, FAME3, back to physiology. So FAME3, you guys all know, it's the blockbuster presented at TCT last year, randomizing patients to either a FFR-guided revascularization or CABG in patients with stable or unstable coronary artery disease and multivessel disease. It was a non-inferiority trial that at the end didn't meet its primary endpoint. Due to the fact that there was a higher risk of TVR and repeat MIs in the and even per-procedural MIs in the PCI arm. So a lot of fuss, a lot of debate following the presentation and publication of the findings. In this case, at ACC, Bill Freeman will present the quality of life data of the trial. I think interesting. It follows a little bit the previous data we got from, for instance, Freedom. in which the quality of life at the shorter term was better for cabbage, but a benefit that actually at the end got lost after 2 years. So that I think makes the results perhaps somewhat more complex to interpret. Specifically for FAME3, what I anticipate and what I hope for is that the authors now will present data on completeness of revascularization, as that was not presented in the New England and not also in the and even on the presentation, because that I think will help to appreciate the changes in quality of life between if there are already any in between both treatment strategies. And I think finally, yeah, we know there is a high rate of TVR in the PCI arm that will affect quality of life anyway. So yeah, well, we will see what these results will tell us and how the uptake will be.
But at the same time, we already alluded to an important limitation of that study, the underuse of, for instance, intravascular imaging, which is really a flaw in this study. Obviously, it reflects the time window in which the trial was enrolling patients. But in this day and age, I mean, you really need to do more and more imaging, invasive imaging-guided interventions, and that definitely will affect TVR rates as well. So I think the true impact of this specific analysis may be limited.
Yeah, we'll see. Yeah. Imaging and physiology, more on that, and that's a very intriguing trial. Again, from Korea, in this case, the Flavor randomized controlled non-inferiority trial randomizing patients referred for PCI to either a FFR-guided treatment strategy or a IVUS-guided treatment strategy. So patients will be 1-to-1 randomized for a primary endpoint of POCHE at 2 years. FFR obviously with a binary cutoff of 0.8, but for the IVUS arm there will be a cutoff of MLA below 3 or a MLA between 3 and 4 and a plaque burden above 70% as the cutoff for treatment. To me, a very intriguing concept in an era which there's still a growing interest in both physiology and imaging in order to improve our outcomes. Conversely, I also have a little bit of mixed feelings due to this trial, because I really don't see physiology and imaging as competing technologies, but rather as synergistic technologies that have their own pros and cons and should be interpreted with caution. But I think combined will be the ultimate goal to proper and better outcomes. We already know that if you do a FFR-guided treatment strategy, you will treat less. Look at Forza, for instance, a 20% treatment difference between the FFR and the OCT arm. How that will affect POCHE at 2 years, I think will be is for me the key thing that I want to learn from this trial.
Yeah, but if you put it in perspective, the field is already moving further. I think you do a lot of research already in imaging-derived coronary physiology, whether it is based on angio, but also you can derive it from OCT and IVUS. I think that is where, as you mentioned, the complementarity of the two principles appear. And I agree with you. Maybe we should not be dogmatic and say, well, let's compare coronary physiology with invasive imaging, because that is a little bit behind us at this day and age.
Yeah, I agree.
Okay, Partita. Now we move to electrophysiology, and this is, I think, an interesting study from Italy, where patients who have an ICD will be followed up, and they will look for appropriate shocks. And then, when there is an appropriate shock, patients will be randomized. So there are two phases in the study. Phase 1 is patients have an ICD, and they will be followed up to see when they will get an appropriate shock for ventricular fibrillation. So they will monitor patients who get non-sustained VT, who get anti-tachy pacing in their observational phase 1. The moment the patient gets an appropriate shock, the patient will be randomized to either a VT ablation or placebo. And that is interesting, of course, and there 590 patients are enrolled, so it's quite a significant number of patients. And what they're going to do in phase 1 is, okay, what is the occurrence of the first appropriate shock? And then can they look for predictors? And then in phase 2, the randomized study will show whether VT ablation will affect heart failure symptoms, hospitalizations, or death. So I think this is quite an important study because we see that in the EP world, we're also moving more and more towards invasive therapies, right? Whether it is surgery or ablation therapy.
Yeah, I think it's interesting. It's a little bit beyond our primary focus, but conversely, this is a group of patients that from any side will I think interact with our practice. Absolutely. Most of them have ischemic heart disease. Conversely,
so it does affect us too, right? So at one point you need to advise your patients, and
absolutely.
And if a VT ablation would help, I think that's very valuable.
Absolutely. Yeah. All right. To move on to the structural field.
Yeah, so we presented the 5-year outcome data of Surtavi, an intermediate risk patient study where patients were randomized to either TAVR or surgery. Now, Michael Reardon is going to present a patient level analysis, pooling data from the Surtavi trial, but also the core valve US pivotal trial. So they look at the patients who reach the 5-year endpoint, and and there will be a really granular analysis of core lab data on the echo study. So this study aims to look for information on valve degeneration, structural valve degeneration, and bioprosthetic valve failure, and it will compare surgery with the supraannular self-expanding valve platform, and that is predominantly core valve, a earlier generation device, but still I think it is of interest because we have some indications that the use of a supraannular functioning valve might be beneficial down the road, especially in terms of hemodynamic valve performance. So I think this might be a valuable piece of information in a discussion on valve degeneration and whether there is a difference in valve durability that you can distract from this between surgery and TAVI. So I'll definitely look forward to this.
Me too. I think it's a hot topic. Whether it was truly an issue, this durability, I think the discussion is changing a little bit with the lessons learned on HAM and HALT and gradients across the longer term follow-up. So I think important data to look out for. Alrighty, more on TAVR.
Yes, and then you already mentioned our colleagues from South Korea are doing quite interesting randomized studies, and there's another one coming in the TAVR space. That's the ADAPT-TAVR trial, where patients who do not have a formal indication for oral anticoagulation will be randomized to either edoxaban therapy or DAPT, dual antiplatelet therapy, and patients will be followed up with brain MRI and cardiac CT. And the ambition is of the primary endpoint, if you will, is the occurrence of new brain lesions and by MRI, but also to look at HALT at 6 months. My gut feeling tells me we already know from registry data that NOACs and vitamin K antagonists will reduce the incidence or the finding of HALT and HAM, reduced leaflet motion, when you do a CT follow-up after TAVR. We still do not know whether there is a clinical implication of this CT finding, but I expect that ADAPT-TAVR will basically underscore what we already know, and that with edoxaban therapy you will have less HALT. But the interesting part is then the secondary endpoint, that do we also see less brain lesions? And I'm not sure there. And there is one elephant in the room, and that is how many patients will drop out because they don't get a follow-up MRI, right? That's always a difficult aspect in elderly patients who enter MRI studies, especially if you have multiple studies. They get a first MRI study, but really the next follow-up MRI, that really is a hassle. So we'll see that this is from that point of view. Interesting. I think conceptually interesting. I have a little bit problem with the DAPT and the control group. I think most of us left the DAPT treatment strategy and routine practice in these elderly patients. So we'll see. I definitely believe that DAPT is abandoned. You should not be using DAPT unless the patient also has a concomitant or recent PCI intervention. But otherwise, it's single antiplatelet therapy. I agree. But in every preview and in every wrap-up, we talk about renal denervation therapy.
Absolutely. So we didn't want to close this preview without mentioning any novel insights into the RDN literature. And in this case, also at ACC, some new data were presented. We already talked about compliance, and this trial is about compliance, at least in my perspective. So it's a 3-year data of the Spiral HTN ONMED pilot trial that enrolled 80 patients, already presented at 6 months findings, learning or let's say demonstrating that RDN with the Medtronic Spiral device is superior to a standard triple medication in terms of lowering blood pressure. RDN on top of this antihypertensive regimen proved to lower blood pressure at 24 hours mean systolic with around 7.4 millimeters of mercury. Now, this presentation by Felix Mahfoud at ACC will focus on the long-term data. There is a lot of discussion and debate as to whether this treatment is durable. Will it be something that it's a one-time procedure that will last for 10 years, or is that something that will suffer from renal nerve regeneration with an effect that dilutes over 3, 6, or maybe 2 years? I think we already know that the delta in the treatment effect will be much lower at the longer term as compared to 6 months, because of the fact that antihypertensive treatment strategies simply will change during the course of the study. Compliance will change during the course of the study, and we also already learned, mostly from the record data at the longer term, that the number of drugs that will be added during the course of the trial is higher in the sham arm as compared to the RDN arm, diluting the effect, but again will attest to the treatment effect. If the durability of the blood pressure lowering effect in the RDN arm remains, in light of the fact that treatment is not significantly changed, something that one of our fellows presented only recently at CRT, in which we demonstrated that for 5 years in our own population, that blood pressure significantly dropped over the course of the years with a antihypertensive treatment strategy that also didn't change. So there was no increase in treatment strategy in terms of drugs, but the blood pressure lowering effect remained, and that is something I hope to be confirmed in this study.
So you're suggesting that the effect of renal denervation is durable?
I think the effect is durable. The only problem of these trials is that it's very hard to adjudicate, because there are no trials with 3-year follow-up in which you randomize just RDN to sham. Mm-hmm. I mean, blood pressure lowering therapy is drugs for at present almost 90% of the cases. And that will bias in any way the results of these trials. So I think compliance data also in this study will be of great importance. What will be drug burden at each of these specific time points, being either the prescribed drops as well as the metabolites measured in urine or blood, attesting to the actual compliance of the patient.
Okay, well, that was quite a variation in trials and different topics, different interests also. So let's see what's happening at the ACC. So you can expect from us a wrap-up after the meeting. We look forward to the results. Thank you for joining us in this preview, and we'll see you again after ACC.
Thank you for watching. Bye-bye.